Hi, I'll be presenting a case of esophageal per oral endoscopic myotomy for a patient with achalasia cardia. This is a 26-year-old male with no significant past medical history, presented with a 6-month history of dysphagia with every meal, regurgitation every day, occasional chest pain, and a weight loss of 7 kg. Barium swallow revealed a classic bird's beak appearance with a diffusely dilated esophagus with tapering at the lower end of the esophagus at G junction. An esophageal manometry showed type 2 achalasia. We discussed various treatment options for achalasia with the patient, including balloon dilation, laparoscopic Hellau's myotomy, and esophageal per oral endoscopic myotomy. The patient chose to undergo esophageal per oral endoscopic myotomy or esophageal POEM. This is an illustration of the esophageal POEM. Basically, it's an endoscopic, incisionless, sort of scarless procedure where the endoscope is advanced into the esophagus, a submucosal cushion is created, and the endoscope is then advanced into the wall of the esophagus, and eventually the muscle is cut, which is called myotomy, and then the mucosal entry site is closed with clips. Here's the video of the endoscopic procedure. So the endoscope is now advanced, the first at the G junction, and as you see, it's quite spastic, and it is hard to get the endoscope across into the gastric side. After applying enough pressure, eventually it gives way and the endoscope is advanced into the gastric side. In preparation for POEM, at 10 centimeters above the gastroesophageal junction, in posterior wall of the esophagus, a submucosal injection is performed with methylene blue and normal saline. There's a nice lift of the mucosa here. Then a through the scope TT knife, which is a knife used for mucosal incision and dissection. Here we see the mucosal incision is performed to gain entry into the submucosal space. Now the endoscope, as you see here, all this blue appearance is the submucosal wall, space of the esophagus expanded. Gentle dissection is performed to create a tunnel in the submucosal space. What you see here at 6 o'clock position is the circular muscle layer of the wall of the esophagus. Using this knife, we continue performing gentle dissection. Sometimes you occasionally see bleeding, as you see here. We use hemostatic forceps, as shown here. It's a coagulation grasper forceps, and using cautery hemostasis is achieved. Right. And then, as you see, there's no further active bleeding evidenced here. Then we continue to perform our submucosal dissection. Now we are reaching the gastroesophageal junction where the space gets narrow, and you have to be extra careful when performing dissection here. On the right side here, you see the muscle layer, and on top is the mucosal layer. The muscle layer is spastic, and therefore this is sort of the more difficult part of the dissection. So we continue to perform gentle, slow dissection. Now we have reached the gastric side. Here, as you see, there are small blood vessels. That's suggestive that the endoscope is on the gastric side of the wall. And then we just continue our dissection for 2 centimeters distal to the G junction, and we have reached our end point here. We'll just gently pull the scope back, and as you see here, the whole tunnel is nicely created, and then we begin the process of myotomy. 2 centimeters distal to the mucosal incision site, we start performing myotomy gently initially of the inner circular layer of the wall of the esophagus. So now here we've continued the myotomy, and now we have almost reached the end of the tunnel. Now we are cutting the muscle at the farthest end at the gastric side of the tunnel. And as we pull the scope back, and you will see at 6 o'clock, a nice myotomy has been performed. So the myotomy in type 2 achalasia is performed 2 centimeters in the gastric side and 6 centimeters in the esophageal side. And then eventually the mucosal entry site is closed with the help of clips. These are through the scope endoscopic clips from Olympus, and right there. So multiple clips are applied, and eventually, as you see, the mucosal entry is closed. All right. So post-procedure patients did quite well, was discharged in 2 days. Follow-up 4 weeks later, he had near complete relief of symptoms, almost no symptoms at all. He had one episode of mild dysphagia, but very short lasting. His weight stabilized, so he was quite happy with the outcome. Thank you so much.